Sabrina. The road is coming.
He's on his way.
Yeah, yeah. Good morning, everyone. Yes, we welcome you on our session. I think that is interest to begin our weekend with you. And as you know that our session is on remaining TB system strengthening. We will explore new approaches from the health system to the community level that work to improve the experience of people with TB. Our session is hosted by GCI and brings together representatives from National TB Program, civil society organization, and implementing partners. Together, we will discuss how TB program are reimagining the approaches to be system strengthening to better achieve country and global goals. Our collection of presentation from our panelists include an overview of utilizing government partnership as catalytic for change, innovation in data accessibility and use, innovative financing models, and the role of civil society as collaborators to increase the effectiveness of key practice for improved TB care, treatment, and prevention. My name is Maxime Lunga. I come from DRC. I'm a TB survivor. I work for a community TB-affected organization called Club des Amis d'Amiens. And I'm not alone. I'm with my colleague to conduct this session. I let her to introduce herself.
Yeah. Good morning. It's my honor and pleasure to co-chair this session. My name is Anna Meltzer. I work at USAID Global Health TB Division. I'm monitoring evaluation advisor for multiple countries. And previously, I have been working at Central Asia and Eastern Europe. So it's my pleasure and honor to quickly go through the schedule. We will have 5 minutes presentation from 4 participants on catalytic government partnership in India. Second presentation will be interactive data use of TB situation room in Nigeria. Number 3 presentation will be innovative resource mobilization, reforming TB care financing system in Kyrgyzstan. And number 4 will be comprehensive civil society collaboration, strengthening person-centered care in Kyrgyzstan by bringing gaps and expanding services.
Okay, now our session is for 40 minutes, and each speaker will have 5 minutes for the presentation, and we will follow each presentation. After that, we will have our moment for question and audience question and moderator guide. And have the pleasure to invite the first one is Venkatesh. Venkatesh is a public health specialist with over 20 years experience in health system strengthening, managing health programs, and working with central and state government. He played a catalytic role supporting national TB elimination program effort toward private sector engagement and strategic contracting. And I invite Venkatesh to have the floor.
Thank you, Chair. My apologies, I was late by a minute. And also thanks to the organizers for motivating us to get up early on the 3rd day of conference. So I'm Venkatesh, I'm from India. I work with Johnson India Private Limited. On behalf of Dr. Raghuram Rao, who is the ADG of Central TB Division, as well as myself, declare that we do not have any conflict of interest. So this is a very interesting subject, which is basically focusing on some of the interventions by the central government of India to reduce largely the TB mortality. In other words, I can say that it's basically to improve the treatment outcomes. So we will just go through the journey. Why problem statement? We all know India contributes largest TB mortality, and we have one of the in TB goal is to also reduce mortality apart from out-of-pocket expenditure and incidence rates. So this is something very, very important to achieve the larger goal of NTB. Why we need this approach? Because we all understand not every person with TB is similar, and we need a different approach. And here the larger focus is to identify high-risk patient and prioritize them first, so that there are successful outcomes. And if you look at the 4 criteria, that's basically a framework where this program has been implemented in different parts of the state. And we will go through it in terms of, this is a very initial journey, and what you look in terms of the data sets is not a comprehensive, but very encouraging. I'm not going to read point by point because of time constraint. I'm sure I'm just adding a couple of additional points to the slide. So the journey started with in 2021, where Government of India released the guidance document on differentiated TB. And it's a very broader document, and there are different models to approach to the high risk, identifying high risk TB patients. So you can see there are 4 different models in terms of health and wellness center, high burden centers, as well as state specific models. And these are the coverage areas by different models. If you look at, these are the 16 parameters, and these are the parameters where every single person with TB will be assessed to understand whether that particular person with TB requires an attention or not. And these are the data sets are from January 2023 till September. And this basically covers the baseline data. So if you look at, that is 13,712, but if you see the frequent interval of assessing every single patient, so we have around 60,000 data sets. Basically, that's more of a repetitive. So these, I don't want to get into this each parameter, why and how these will help us to identify a person with TB with high risk. We can obviously catch up after this presentation. These are the different models, and quickly in terms of understanding different pros and cons, I would like to focus on the bottom of the boxes in terms of the key learnings, right? So biggest challenge in the healthcare facility is convincing the practitioner, a medical doctor, that there is a protocol identifying high-risk TB patient, but they have their own practice experience, right? So there is a kind of behavioral change communication across different providers is something which is necessary to convince. Like for example, low BMI. We all know that most of the TB persons with TB will have a low BMI, but that is considered as a usual practice. It's a very common. What is the point, referring to a specific facility? If of course there are thresholds, but I think one big challenge is to how do we convince to the providers that this is what the protocol and you have to adapt, so that we can save as many as lives as well as improve the treatment outcome. One interesting fact is that 60% of TB mortality happens within 2 months. So that's another very important point to remember. So these are some of the statistics. I'm not going to get. These are estimated numbers if you look at the comorbidity management based on data availability in the system, and what we are going to expect, what we are expecting as a result of this program is 20% reduction in the mortality, and also improving the treatment outcome. So way forward, we are working closely with Ministry implementing such models in different states. State themselves have also implemented. So when I say we, TIFA is providing specific technical assistance to the selected state so that states can adapt and implement these models. Finally, I would like to acknowledge our implementing partners on the ground World Health Partners, William J. Clinton Foundation, JAPIGO, and state and TB teams, and most importantly, Dr. Raghuram Rao, who is really a catalytic person who taken it forward from the Government of India. Thank you.
It's my pleasure to introduce our second speaker, Dr. Abioma from National TB Program of Nigeria, who will talk about interactive data use in TB situation room in Nigeria. A little also introduction on Dr. Abioma background. She's presently Monitoring Evaluation Manager of the Program Management Unit at the National TB Program in Nigeria. She serves as the Secretary of the TB Operational Research Task Team in Nigeria and has been involved in public health research in and outside of the country. She presently joins in conceptualization, operationalization, monitoring, evaluation strategies in the Nigeria TB program and has led the development of the TB National Strategic Plan twice in a row. Dr. Abioma is a data fellow and has worked several years informing program decision using data trends. Over to you, Dr. Abioma.
Thank you so much. Thank you, Chair, Co-Chair, fellow panelists, and everyone. I want to thank you for this opportunity to present on this platform, and just to state that I have no conflict of interest to declare. So I'm talking on interactive data use, using a TB situation room in Nigeria for real-time decision making. And I just want to give a little background. A country, more than 200 million in population, and we have 36 states, subdivided into 6 geopolitical zones. For the past 5 years, Nigeria has seen increase in the number of TB cases identified, and at 2022, we identified more than 280,000 cases. And that sure tells you that there is need for us to do a lot more in exhaustive data analysis. To give a context, data use is important in public health service delivery, and it helps to establish access and impact changes, especially when it has to do with intervention. A whole lot of people say things like data speaks. And when they say that, I ask them, I said, on which platform? It depends on the platform. Because it can be speaking on an apparent platform, making informed decisions, or in a closet, in a hideout, heaped together, and may never make the changes as made to me. And this is one thing TBDI did for us, to give us a platform for this data to speak. And in doing that, the established situation room, they helped us to upgrade the situation room we had at the center, which is the national, and also at the subnational level in 3 states, 3 high-burden states. They also helped us to establish that. There are key features for this situation room, and most especially gives real-time access to data. And it makes it apparent for the management with even little knowledge about use of data to be able to make informed decision. In setting up the situation room, there are steps that were taken. They did a needs assessment. Believe you me, when they started this, I was wondering why it took all these steps to just establish a situation room. But when the situation room was over, I had to relearn. There's importance. The needs assessment is important because there's an ecosystem of health. It has to be people-centered, and you have to get the voices of the people who would either need this situation room or who this situation room would serve. So before the procurement, SOP development, and all that went in, an SOP for a situation room, and I asked TB, what are we doing with SOP for situation room? Well, recently, at an attempt to misuse the situation room, I told this person, I said, read the SOP. You're not supposed to do this at the situation room. So the results and the things we have seen has been amazing. At the launching of the situation room, it was very emotional for me, standing in front of the USAID, and you could see the satisfaction they had with the detailed data analysis from more than 20,000 health facilities. we could see the data facility by facility just by a click. You see the whole interactive dashboard, show you whatever. So you can pinpoint just a clue from that kind of volume of data. And we're able to display different thematic area, the lab, the procurement and supply chain, and be able to triangulate what happens in our states. So it's a journey. It's a startup for us also, but we've been able to use the situation room. The recent USAID monetary evaluation assessment was exhaustively done in the situation room. So the impact of the situation room in Nigeria cannot be undermined, because we, even in the national program, have seen the use and addition. Thank you so much.
Thank you, Dr. Obiama. And now we would like to invite Dr. Ibrahimova from the Cure TB project in Kyrgyz Republic to tell us about the innovative approach to resource mobilization by reforming the TB care financing system in Kyrgyzstan. Dr. Ibrahimova is a chief of part of USAID's Cure Tuberculosis project in Kyrgyz Republic. Ainora has over 20 years experience building and strengthening dialogues among national and international health organizations, governments, and donors. Since 2014, she has led USAID-funded tuberculosis activities in the Kyrgyz Republic, which is regarded as a leader in the fight against TB. She served as Deputy Minister of Health in the Kyrgyz Republic from 2000 to 2008, and before that, she helped establish the country's first mandatory health insurance fund. Dr. Ibrahimova has a background in medicine with training in public health, health financing, and public policy. Dr. floor is yours.
Thank you, chairs. Good morning, dear participants of this session. And I have no conflict of interest to present innovative resources mobilization. My presentation will illustrate how Kyrgyz Republic is reforming TB financing. The reform of healthcare financing starts in 1997 in Kyrgyzstan, when a mandatory health insurance fund been established. Reform of TB financing started later in 2012, when the government transferred the financing of TB services from the Ministry of Health to the mandatory health insurance fund. I will call this entity as an MHIF further. Some little background. The analysis conducted by the MHIF when it was transferred to them showed that the TB care system characterized by lack of efficiency and lack of focus on patient-centered services. In particular, financing of capacity and infrastructure on an item-by-item basis, mandatory hospitalization practice, inflated bed capacity of TB hospitals, threat of nosocomial infection, lab network is fragmented and inefficient with limited funding for diagnostic services and materials, lack of incentives for medical personnel at primary health care to manage TB cases. The strategy developed by the MHIF to reform the financing of TB services aims to establish a financing system for TB organizations, hospitals, and PHC facilities aimed at improving the quality of TB services and achieving TB health policy goals. The main directions were optimization of TB services, restructuring of the TB system to shift focus from inpatient to outpatient services, reduction of the hospital network, introduction of mandatory reinvestment of savings into TB services, creation of financial incentives for transferring TB services to the outpatient level, introduced inpatient DRGs with high coefficient for multi-drug resistant TB cases encourage hospitalization of these forms. At the same time, they introduced payment per treated cases at primary health care level, provide financial incentives to treat TB patients at the outpatient level. According to the strategy, starting from 2012, all standards for financing TB services are approved by the MHIF budget law by our parliament. MHIF introduced new methods for financing new functions of TB services, such as norms for financing coordination for regional TB centers, the possibility of outsourcing transport and laboratory services, implementation electronic filing requirement for payment helps to get transparent and reliable data for MHIF. Since 2017, Kyrgyzstan for the first time introduced payment for successful treated cases at the primary healthcare level. Principles of payment were differentiation based on case complexity and degree of involvement of PHC staff. A resistant TB case is paid at a higher rate. MHIF requires electronic submission of treated TB cases with verified treatment outcomes for payment. Source of financing, Republican budget. To ensure that TB patient provided by lab services, outsourcing mechanisms are developed and implemented. This slide shows some results. Optimization of TB hospitals and implementation of output-based financing resulted in reduction of TB hospitals network, would help us to reinvest savings to TB program. Gradual expansion of incentive PHC payment to other regions has led to an increase in the number of successful treated TB cases for which payment were issued. Organization and financing of the transport system of biomaterials and TB drug led to more than a 5-fold increase in the collection and delivery of samples for TB testing. Proposed increase in financing for successful treated TB cases at PHC started from 2024, resulting from effective management of available funds and the system verification. Thus, TB financing reform have led to reorganization of TB services and enhancing efficiency allows reinvestment of cost savings into improving patient-centered care to TB patients at PHC, including more efficient transportation services of biomaterials and drugs for TB biomaterials for TB testing, and as well as drugs, strengthened laboratory services, compensation for successfully treated TB cases at PHC. I want to stress here that financing methods are just only one element of broader comprehensive reform effort, which includes laboratory optimization, increased access to services, integration of digital health solutions, the nationwide system of transportation of materials and medicines, implementing the TB case management approach at PHC, and community-based treatment support. Through the combination of all components of comprehensive TB reforms, including reform in the TB financing system, Kyrgyzstan can have a tangible impact on TB system strengthening and the delivery of more patient-oriented care. Thank you very much.
Thank you. Thank you. It was excellent presentation. And Last but not least, we will hear from Dr. Marat Kachinbekov from the Red Crescent Society in Kyrgyz Republic, who will present on how comprehensive civil society collaboration works to bridge gaps and strengthen person-centered care in Kyrgyzstan. Just a few words about Marat. He's a public health and organizational development professional with more than 20 years experience in TB/HIV health promotion and organizational capacity and development. He currently serves as advisor on strategic development and international relations at Red Crescent Society Kyrgyzstan, as well as vice president of the European Red Cross Red Crescent Network on HIV, AIDS, tuberculosis, and substance abuse. He provides leadership support and contributes to policy development, resource mobilization, and fundraising. Marat is committed to international approaches and standardization in development and project management, as well as integrating traditional and innovative methods of work. Over to you, Marat.
Thank you so much, Anna. Good morning, dear ladies and gentlemen. And it's really early morning, especially on Saturday. And I would like to thank to all of you for your willingness coming and participation in this session. So my name is Marat Kachinbekov, and I'm advisor of the Kyrgyzstan Red Crescent. And today I represent the USAID QETB project in Kyrgyzstan Red Crescent part. So I'd like to say that I don't have any conflict of interest within the reporting right now. And so the next slide is about the name of my presentation and my position again. So here I would like to invite some kind of context related to my presentation. So Kyrgyzstan, as you know, is one of the 30 countries with a high burden of tuberculosis, both sensitive and drug resistant. So, and Kyrgyzstan being part of the global Kyrgyzstan Red Crescent being a part of the global Red Crescent system is a multi-profile organization working in different areas like disaster preparedness and response, health promotion, providing social care for different categories of the population. And for us, tuberculosis is only one of the directions we are working on. So, and currently we are implementing 2 projects supported by the USAID. The first one is the USAID QETB project, and where the GSI is the prime recipient. And also we have here Red Crescent, TB People Kyrgyzstan, Association of Village Health Committees, like a sub-recipients within the project. Another project we are also implementing right now is the USAID TB Loan project. So, and in addition to this one, we are hosting Secretariat of CCM in the country and also Secretariat of ERNA. ERNA is a European Red Cross Red Crescent Network on HIV and TB. So, additionally, in the country, we have a national law about Kyrgyzstan Red Crescent, which is regulated on the national legislation that makes our organization a little bit special. So talking about the models of the Kyrgyzstan Red Crescent, so we have here some very important components. For example, here we are providing auxiliary role to the state case management system, implementation of the person-centered care model comprising treatment support, counseling, and links to services. Also, we are providing psychosocial support for the clients, and based on the group sessions and individual talks. We are also working on engagement of volunteers and especially those who are ex-TB patients. Providing food and hygienic vouchers to motivate treatment, home visits to the clients as needed, providing consultative support, referral to other health services, raising awareness among the population. That is also very important to know about tuberculosis among the population. TB screening and returning people to treatment course. And also we are working on reducing stigma and discrimination. So here on this slide, you may see the overall accomplishments within the project for the period December 2019, September 2023. So, and we have here the population covered by the informational sessions, population covered by the mass media, and also we have here the figures about people covered by TB screening, people returned to the TB treatment, And also we have figures about people covered by direct TB services and treatment outcomes. Challenges, of course, all of us, we have challenges within our program implementation here, and we have such challenges like migration, both internal and external, stigma and discrimination, all kinds of stigma and discrimination. And also one of the challenges is to provide long-term support, long-term commitment within TB prevention program. So, and talking about the sustainability, which is quite crucial to be mentioned because, you know, for example, our organization, we are trying to develop the sustainability from the very beginning. And so here we may rely on the community's volunteers that they can continue their work after the project time frame. Also, we have the system of the state social orders, which is provided by which is currently piloting by the National TB Center, and potentially it's also opportunity for us to continue. And also continuation within the USAID TB loan project, which is focused on the national capacity building. It's all about sustainability. And so taking the limitation in time, so that's all from my side. I'm available for the questions and answers. Thank you.
Thank you so much, Marat. I think we would like to thank all our presenters. And I think we can start a question and answer session. So if I think there is a function to submit your question online, but maybe we can start from our audience who wants to come up to microphone and ask questions. I think it's really important to look at the areas of discussion, such as how person-centered care on system level is emerging, sustainability, overall system level approach, and health system strengthening. So if anyone is interested, please, please, Nicholas.
Good morning, everybody. My name is Nicholas Nasidze. I'm Senior TB Advisor for Uzbekistan, supported by the USAID STAR project. First of all, many thanks to all presenters for the very interesting experience shared. And I have two questions to the two presenters. And the first is to the Kyrgyzstan, to the country which is close to my heart. And I'm really happy to see this really revolutionary reforms on the financing, which is really a must point to achieve the patient-centered approach. And all elements that was listed were really essential, but I think that the key element is the reinvestment of the funds in the TB. So this, I think, it would be nice to hear. And here, probably, we need a really strong governmental commitment to this. So it will be probably useful to hear a little bit more about this, how it was achieved in the country. And another question for the Nigeria. Again, thank you very much. And just a simple question, are the situation rooms, TB situation rooms used only for the data analysis, or some clinical aspects are also discussed and consulted through this? Thank you.
Thank you so much, Nicholas. So over to Aynura Sultanovna about the first question.
Thank you very much, Nicholas. And I think that we can discuss later about maybe some features of our system. But what I would like to say here, how really Kyrgyzstan was able to achieve such revolutionary changes in TB financing. First of all, everything, I think that about people. And to have people at the level of leadership of Mandatory Health Insurance Fund and the Ministry of Health, this is essential to get, and actually at the Parliament. I think that what the NTP and project did, this is just quite high level of advocacy work to with this leadership to explain people why the system is not working proper way and what is necessary to do. And luckily for Kyrgyzstan, this advocacy work actually help us to go through this exercise, and as well as working with Parliament, because to get this budget law improved or approved, it was really revolutionary, and we consider this as a, just very big achievement of TB program in Kyrgyzstan. Thank you.
Okay, thank you for the question. The situation room is used for data analysis mainly, but in establishing it, we also have in mind that there may be need for us to also have clinical discussion. So we have an ecosystem embedded in it, which gives opportunity for that. Presently, we've not had any opportunity to have such because of the Consortium of Best Practices. We've been able to decentralize in states, which have opportunity to have such clinical discussion at the state. But we also have it embedded such that if there is need to have such upscale to the central level, there is a platform for it. Thank you.
Please, Inosa, please.
Thank you. First of all, I want to really thank all presenters for these great presentations. Yes, so, yes, my question is for Dr. Obioma from Nigeria about the TB situation room. Is there like a plan from, I don't know if the Ministry of Health is really involved on that, and is there any plan for sustainability? Meaning that if tomorrow USAID suppose no longer there, is there a plan for the government to take over and stick running the system? Thank you.
Okay, so the system is already sustained because it's already embedded in government, and it's not something that you need resources to start fixing into resources or hiring a human resource. No, every capacity have been able to be built into the national program. So the data, we just used the one produced by provided by the Ministry of Health. So everything utility built by the Ministry of Health. The only aspect is that ability to manage the system situation room and ability to have such interactive data dashboards built, which TBDI has all done. So the management of the situation room from the launching has been handled. Everything about the situation room has been handled by the national program. And good enough, we were also able to display our website. We have a new, improved website. I just want everybody to just go check for Nigerian TB program. It is so simple and amazing website for the states. It was like it's when we display the website for the states. It's for every state seeing that you can go to the website and see your location. Geolocation, latitude, longitude, our patients can find you, was really a very big stride for the TB to do. So it's also displayed for us. So it's just a one point you can come in and see a whole lot of things in the program. When we have visitors and we just want to, instead of just speaking and telling you, oh, we did this, we did that, we just take you to the situation room. By the time you're done with the dashboard, you're excited for what the Nigerian program is doing. Thank you.
Thank you. I think we have one more question, and I believe it might be the last question.
Thank you. I am Sanjana. I come from India, and thank you to all the presenters for giving us, different ideas for really reimagining the systems. I have a slightly different question, and to any of the speakers and the moderators of the session. So, a big issue that we see is, the patient's own sort of dissatisfaction or fear or avoidance of going to the public health systems. And the common narrative that we hear of is that people don't talk to us properly, they don't, the doctors and nurses, they don't behave with us properly. But we also see this going back. So a nurse is, her own behavior is affected by how her seniors speak to her, and the doctor's own behavior affected by how their seniors speak to them. So it also has to do a lot with the health system's own motivation and interest. So my question is that are we doing something or any experiences of working on motivation of doctors and nurses and other healthcare staff?
Thank you. It's a great question, and I think maybe we will give opportunity for our speaker from India. I think something has been brought up, how to change attitude of healthcare providers on this risk assessment, different groups of risk.
Yep, thanks. This is a very interesting question. I largely, speak from India's perspective, and I'm sure that you also aware a couple of initiatives by the government. Yeah, that's very important question. Still, we have huge issues, but I think the recent, I would say, reforms within health setting has, they're trying their best to bring such elements. To say so is, I think, Kayakalp is one such initiative. It's, how do we really, it's not about behavior, but, in the context of India, it is also the ambience of the facility, right? If you many of you might have an experience visiting, Indian crowded healthcare facilities, they're not really that conducive, right? So I think these programs are also covering, how to really improve, the ambience along with the behaviors of different staff. But I think this is a big challenge, and I don't think that it has any quick immediate remedies for this. It's a constant process to bring change, and that's I generally believe that any social change is very hard to happen, right? So this is something to do with the social behavior of the human being. It's a very broad response, but I'm sure that you.
I apologize. We need to wrap up. And maybe a few seconds, Ainura Sultanovna.
Just few seconds.
I think you have a good point. I think with financing you can change behavior.
Yes, financing. Actually, I report about financing. That's why I'm not going to talk about it. I want to talk about different way to provide incentives for medical personnel, and this is to invite them as trainers, maybe for another so just to establish this peer-to-peer talk. And we actually, because in Kyrgyzstan we are doing this in as a pilot basis, so we inviting the medical personnel from our pilots and bringing them to another oblast where we still didn't start the reforms, and they're talking to them. And they actually feel this, I think that participation in such a great processes, and I believe that this is again a very good mechanism. Thank you.
Yeah, excellent. I think we have to wrap up our session. I would like again to thanks all our speakers who prepared excellent presentations. And thank you for all our audience who came so early on Saturday morning. Thank you so much. I think it was an excellent, outstanding question. I encourage any other unanswered questions, please reach out directly to speakers. And I wish everyone to have an excellent, the remaining part of our last day of the Union Conference, and a great remaining stay in Paris.